Dear colleagues and friends, welcome. But before starting today, I want to say a few words because I want to really thank Linda and Luca, because dear Linda and dear Luca, before starting, as I said, the last webinar, I want to thank you for the great work that you have done, a great and impressive work that you have done for you in ENPS. And thank you above all for the pleasant atmosphere of familiarity that you have created in this fantastic and enriching journey. The speakers and the topic you chose were all of the highest level, as demonstrated by the constant, extremely high number of participants. About this, Federica, could you show the slides related on the data of this module? As you can see, this is the registered people. This is the viewers, 7,400. And this is the people who attended the webinar recorded. So a very, very big success. Really, thank you for what you have done. And so, I think also you are impressed by the high number. And I underline from 133 different countries. This is really fantastic. So very good job. And now I would say, dulcis in fundo, I leave the floor to Linda to introduce Professor Nikki Robertson, another very important name in the field of neonatal neurology. And I like to underline that she's also a member of the scientific board of ENPS. Thank you. Please, Linda, the floor to you.
Well, thank you once again, Professor Moretti, and also Professor Noy and Zogstad from the UEPNS for giving us the opportunity for Luca and me to do these modules, which have been really very nice to do. And we were very lucky to get such excellent speakers as well. And it's really great pleasure for me today to introduce Nikki Robertson to you. And of course, Nikki also doesn't need any introduction. But yesterday we talked about the long-term outcome of HIE, and we learned that hypothermia does help, but it doesn't help completely. So we need other things. And like Donna Ferrero tends to say, cocktail on ice, something additional to the hypothermia. So Professor Nikki Robertson is a neonatologist who trained in neonatal medicine in Melbourne and London after completing her medical training in Edinburgh. And she first became interested in the neonatal brain when she was working in London at the Hammersmith Hospital in the late 90s. And since 2003, she has been working at UCL, University College in London, and has been using her preclinical models to assess the safety and efficacy of additional therapies that can complement and synergize with hypothermia. For instance, melatonin, I'm sure she will talk about that, as well as human umbilical mesenchymal stem cells. And since 2020, she has come back to the place where she did her medicine, and she is now also a professor in perinatal neuroscience and an honorary consultant in neonatologist. Well, I've known Nikki for many, many years, and I always enjoy listening to her very much. And I can't think of a better person to give this talk and be the last talk of our 5 modules. So Nikki, please, the floor is yours.
Well, thank you very much, Linda, and all of the organizers of ENPS. This is a fantastic honor and pleasure to be part of this. I've enjoyed your sessions enormously. Can I check you can see and hear me okay? Yes. So I'm going to try and cover quite a lot over the next 40 minutes or so. I think we've learned a lot about neonatal encephalopathy, and we're still learning. So I want to just go back to some basics that will guide us to the best therapies. I'm going to talk about some of the unexpected findings in 2021, 2022, and then some of the exciting developments in new therapies for high-income settings, and also touch on some of the developments for new therapies in low and middle-income countries. And then I'd like to try and speculate where we might be in 5 years from now. So first, to talk about some of the key concepts of neonatal encephalopathy, looking at one of the big issues, LMIC versus high-income countries, sex dimorphism, and a very important aspect of the evolution of injury and making sure we're targeting the therapies for this right phase. It is a significant problem across the world, neonatal encephalopathy, with over 1 million neonates affected. Most in high-income settings occur after sentinel events, but only around 20% in low and middle income settings occur from sentinel events. This graph, I think, tells so much in that there's huge inequality across the world, in that there's 10-fold increase in the incidence of neonatal encephalopathy in LMICs, such as sub-Saharan Africa. And the other important fact is that neonatal encephalopathy is more common in boys. And you can see that with the white boxes compared to the black boxes, which are girls. We also know that infection and inflammation are key risk factors for neonatal encephalopathy, certainly in sub-Saharan Africa, where we've done some work. And this is from some of Kali Tan's work. So we are in a situation where we have to try and tailor our therapies according to which setting you're in. So in the high-income settings, such as UK and Europe, therapeutic hypothermia is now standard care, with a number needed to treat of around 7 to avoid 1 adverse outcome at 2 years. However, we know now that despite cooling, around 20% develop CP, and of those, up to 60% have these cognitive and behavioral problems that we heard about yesterday with Linda's lovely talk. In LMICs, it's a different situation. Hypoxia may have been going on for several hours. There may not be optimal resuscitation, and other comorbidities such as sepsis exist. We know that cooling is unlikely to be as beneficial in this setting, and we're now looking at preclinical studies focused on therapies without cooling. And of course, we will touch on the study in Southeast Asia by Thiel and colleagues in a little bit. I think really important to understand is the sex dimorphism in neonatal encephalopathy, and clinical data in hypoxia ischemia outcomes show that males have more severe cognitive and behavioral deficits than matched females. But the neuropathology appears to be the same. It doesn't appear to just be down to the estrogen, the estradiol, which is neuroprotective in many types of brain injury. The hormones do not fully account for the sex-specific responses to cerebral ischemia. And there's some beautiful work that has looked at the different pathways of cell death in male and female cells, showing that males tend to undergo cell death through excitotoxicity, and females through cytochrome and more programmed cell death. And this, I think, is really key, with 2 points in that we, in the preclinical world, must include both males and females in our studies, and it is possible that we might be targeting or using different therapies in male and female newborns. So preclinical models have had a long history in informing us of term hypoxic ischemic injury, and have led over the last 70, 80 years now to our current understanding. Some of the first studies were done in primates in the 1950s to 1970s, and these very elegant studies already showed us that there are 2 main patterns of brain injury that depend very much on the type of insult, be it acute total asphyxia or chronic partial asphyxia. We then went on into the 1980s, where we had a more economical platform, the Rice-Venucci model, to assess therapies and the benefit in a high throughput model. And then we move on to the large animal models, the piglet and the fetal sheep. And many of these studies gave us the confidence and data that allowed us to move on into early phase clinical trials of cooling in babies, and then into the bedside and adoption of therapeutic hypothermia as routine care. It's important to note that some of these models, especially the rodent models, lack the complexity of the brain development and gyroencephalic morphology that is needed to really model what's going on in the human neonate. We really have to understand the disease, and I think the early work using MR spectroscopy and understanding the evolving nature of secondary energy failure are really key. These data are old, but I love to go back to them because they tell us so much. In this first, on the left-hand side, in this series of spectra, taken from one single baby with birth asphyxia, taken downstairs to the magnet at 8, 31, 36, and 55 hours, you can see that there's an evolving pattern of secondary energy failure with a reduction in ATP peaks and an increase in your inorganic phosphate in that same baby. This team was led by Oz Reynolds and Dennis Azzopardi, who you all remember from the Toby trial, was the first author. You can see on this cartoon of what we think is happening to the energy levels within the brain in the primary insult during hypoxia ischemia, recovery, and then secondary energy failure when these spectra were taken. And from this series of studies that were done in not just one lab, but several labs around the world, we have defined what we think is going on in terms of the evolving nature of energy failure and in parallel, the changes in AEEG, the changes in cerebral blood flow, and the pathogenic mechanisms that occur in parallel to these evolving changes in the energetics. And you can see that the pathogenic mechanisms are key to understanding which therapies are going to be most effective and when. It's also important to note that we have focused very much on the latent phase and trying to prevent the secondary phase, but not so much about in the tertiary phase for regeneration and repair. And this is an area of intensive research just now. So following those very elegant studies, the team at UCL then went on to look at the effect of cooling in the latent phase. And some seminal data, and Marianne Thoresen was the first author of this paper, showed that if you start cooling in this early phase, you can change the trajectory of the energy failure such that you can see improved energy levels in blue compared to decreased energy levels in red. Of great importance was that these changes in the energy levels in the first week after birth correlated with outcome and head circumference at 1 and 4 years. And in a similar way, because phosphorus is not available on all of our magnets, people have now focused very much more on proton MR spectroscopy and the ratio of lactate to N-acetyl aspartate. And you can see that in a severe injury, you have a very high level of lactate and your NAA is reduced, leading to an increase in that ratio. And again, you can see a change in the trajectory if you introduce cooling in that early phase. And of course, now we are very keen on using the ratio of lactate to NAA as one of our primary outcome measures. So one of the things that was so important from Linda's talk yesterday is even though we've come a huge way with cooling, we are in a situation where school age outcomes are quite concerning. In the recent systematic review of children more than 4, up to 60% of cooled children show impairment of general cognitive abilities. And this is correlated to abnormal white matter microstructure and reduced connectivity. So we need to have adjuncts that can be added to cooling. And so this is a diagram made by Ray Pang, my PhD student, and I think it's a sort of modern day diagram showing that we need to be using agents that target the early phase to manage to target oxidative stress and the downstream effects of mitochondrial failure and cell death. And these are the sorts of pharmaceuticals we might be looking at, and different agents such as stem cells to look to target the later phase. The current protocols for hypothermia are near optimal, and there have been studies looking at deeper and longer cooling, but 72 hours at 33.5 degrees appears optimal. Cooling for more than 6 hours and less than 24 hours, this is controversial, but the efficacy suggests that there may be some benefit, but it is clinician dependent. We're awaiting clinical trials for mild encephalopathy and also for near-term babies. So the best ways to improve outcomes is acute brain injury protection with refining our neurocritical care and adjunct therapies. So I'm going to focus on adjunct therapies in my next but one session, but I want to just stop and look back at the last couple of years and look at some of the surprising results. Cooling in LMICs. This is a landmark paper, the HELIX trial, a multi-country, open-label RCT in 7 tertiary NICUs in India, Sri Lanka, and Bangladesh. And you can see here, there was no benefit of cooling in the 408 eligible infants, randomized 202 to hypothermia, 206 control. All recruiting sites had invasive ventilation, cardiovascular support, and 3 Tesla MR spectroscopy. But the patient group was very different. Most infants had white matter injury, suggesting that the insult was not sentinel, but much more intermittent. And then a key aspect was that most infants had clinical seizures within 2 to 3 hours of birth, indicating an early antenatal onset fetal brain injury. And furthermore, we can't really exclude chorioamnionitis, as only the cords were examined for phonocytis. So these patients were quite different. There was white matter injury in up to 80%. There was very early seizures at around 2 hours, so well before cooling could start, and fewer sentinel events. So there was a lot of discussion around what should be done, and rather than stopping cooling in all LMICs, it has been discussed that perhaps we should be focusing on particular babies with sentinel events, for example, looking at perhaps earlier cooling or other therapies. So at the moment, with the Gates Foundation, we are looking at monotherapies without cooling, but more of that later. The other big surprise, I think, to many of us was the negative HEAL trial. EPO has been a hot favorite for many, many years as a possible adjunct therapy with cooling. Of course, EPO has a very pleiotropic effect. It modulates inflammation, angiogenesis, neurogenesis, and promotes white matter development. But there is some concern over the U-shaped dose response curve. And actually, when you look at the studies in sheep and piglets, there was no additional effect of EPO over and above cooling. Indeed, the phase 1 and phase 2 studies that were done with Yvonne Wu and Sunny Jewell were very promising, but the actual HEAL trial was negative. It's interesting to speculate why this was negative. The preclinical studies were mainly in primates and rodents without hypothermia. It may also be because hypothermia and EPO have similar mechanisms of protection acutely. They are both anti-inflammatory and anti-apoptotic. It may be there was suboptimal dosing. And also this other issue of clinical chorionitis. Maternal fever was present in around 15% of the 500 HEAL subjects, and almost 40% had histologic chorioamnionitis. So it may not be working in this inflammation augmented model. So it's back to the drawing board to find other therapies that will be complementary and additive to cooling. And I think it's a very sobering and important aspect to look at which therapies achieve all the ticks to move on from bench to bedside. And that's some work that we might start to embark on in trying to look at similar guidelines as in stroke models. This is to show some of the work from Alistair Gunn's lab, showing that when he looked at therapeutic hypothermia and EPO on their own, there was benefit, but when you added the two together, there was no benefit. And suggesting that co-treatment had no additive effect because of the overlapping mechanisms of action. And this is some work from our own piglet model when we looked at cooling versus cooling plus melatonin, cooling plus EPO, and then cooling plus the combination of the three. I think looking at the metabolomic effects of melatonin versus EPO versus a combination show very clearly that the most change in the upregulation and downregulation of the metabolomic signatures occur with melatonin. And there's a very little in the way of upregulation or downregulation of metabolomes with EPO, suggesting that it's probably not something that is going to lead to benefit over and above cooling. So moving on now to new therapies that we are trying to actively develop and take from bench into bedside in high-income settings. We realize now that cooling is not the silver bullet, and so we've had to go back to the bench and use a range of animal models to try and understand safety, efficacy, pharmacokinetics, and translation of therapies as cooling adjuncts. Melatonin is something my lab has looked at over the last 10 years. Melatonin is one of the first biological signals and is seen in even the most primitive organisms. Melatonin, we know, is secreted endogenously. We have high levels of melatonin at around 4 in the morning. It is called the healing hormone that is triggered by darkness and inhibited by light. But we're looking at pharmacological levels of melatonin, so 10,000 times what we secrete in the middle of the night. And when you come to this sort of level of melatonin, it has remarkable effects on brain protection. The first and most important is a free radical scavenging. Melatonin is probably one of the most potent free radical scavengers around. It also has anti-apoptotic effects, anti-inflammatory effects, and also receptor-mediated gene regulation. Melatonin is highly lipophilic, which means it crosses all membranes, blood-brain barrier, and is actively concentrated in the mitochondria. It has a significant benefit to energy production in the mitochondria, scavenging free radicals in there, protecting the integrity of the electron transport chain, improving the levels of cytochrome oxidase, and protecting mitochondrial DNA. So it really gives a sort of tonic to the cell to kickstart it into living rather than dying, called anastasis rather than senescence. So we've spent a lot of time looking at melatonin with different doses, different ranges, and different models. And we then, Raymond Pang, my PhD student, took the initiative to then move on to look at a systematic review and meta-analysis of all the preclinical studies in all the different models, rats, mice, piglets, and sheep, to really get an idea of the efficacy of melatonin in term neonatal models. And more people are looking at these meta-analyses to try and gain confidence to move from bench to bedside. It was very clear, pooling all this data, looking at reduction in infarct size, improved neurobehavioral outcome, and reduction in cell death. Melatonin added after hypoxia ischemia was significantly beneficial. Not only that, melatonin was beneficial as a single agent, it was also beneficial when added to cooling, i.e. giving added benefit over and above cooling. So we are at a stage where we are, I think, confident of the plasma levels of melatonin that is needed for optimal protection, and the probable dose of melatonin that is needed to be given at around 2 to 3 hours to achieve that therapeutic level. The timing is really critical. We need to target those free radicals, and we need to get those levels up within 3 to 6 hours after birth, as we saw reduced protection when levels were achieved after 8 hours. But one of the key things that has held us back, as probably many other groups as well, is the poor solubility and need for an excipient. On the one hand, melatonin's lipophilic nature is really important and a key to its benefit, but on the other hand, it's difficult to make solutions. People have used different excipients, the DMSO, tween, cyclodextrans, and ethanol. There's no chance of translating DMSO and tween into babies, and I won't talk further on those. But I want to just talk to you a little bit about us using cyclodextrans and then ethanol as excipients. This to show you there's multiple studies that we've done to really hone down on the pharmacokinetics that are needed, and this in green, 20 milligrams per kilo is really the sort of level that we need to get to in babies. And just a word to say that we don't feel that giving melatonin orally is going to give enough bioavailability to achieve these levels, especially in the sick babies with encephalopathy. So this is just a little bit of a translational pipeline to show you how long it takes to translate a therapy from bench to bedside. So it was back in 2013, we saw in our paper in Brain that melatonin really robustly augments hypothermic neuroprotection. We used an ethanol excipient. We then went on and achieved orphan drug designation for melatonin as a treatment for perinatal asphyxia. This is something you can obtain in the EU for prevention or treatment of life-threatening or chronically debilitating conditions that occur in less than 5 in 10,000 people in the EU. We then partnered with an industrial partner, and a formulation with cyclodextrans was made. And this was because it was felt we should really avoid at all costs any ethanol. But then the safety concerns of beta-cyclodextran began to surface and relate to the vacuolation of organelles and the renal problems. And the EMA actually are contraindicating cyclodextrans in newborns due to the scarcity of safety data. So between 2014 and 21, we were down a rabbit hole in pursuit of a formulation with reduced efficacy and potential toxic excipient. But then in 2021, 3 events changed our focus back to melatonin ethanol. We looked at some of our data and saw that actually the ethanol as an excipient was giving partial protection. We obtained scientific advice from MHRA, and also the systematic review that Raymond Pang did showed that actually there was benefit in the melatonin ethanol formulation over other formulations. And this is a key paper where we used in our piglet model 3 groups: a control, hypoxia ischemia and cooling, hypoxia ischemia and vehicle, which is ethanol, and hypoxia ischemia plus melatonin plus ethanol. And what you can see in our AEEG recovery, in red was the cooling alone, in blue was the ethanol, and in green was the combined ethanol and melatonin. You're seeing partial protection of your EEG recovery. In your cell death, we're seeing partial protection from ethanol in the blue here, and also in the oligodendrocyte survival, ethanol is really improving outcome with the survival there. So long story short, several years later, we are now in a position where we are hoping to move towards the Acumen study, which is acute high-dose melatonin for encephalopathy of the newborn. And we're hoping very much to move on to a phase 1 dose escalation study at 6 centres in the UK and Ireland, looking at quarter, half, 3/4 and full dose, and then a cohort expansion in up to 20 babies in 8 centres in UK, Ireland and Australia. We have subsequently achieved FDA orphan drug designation for melatonin and ethanol as both actives in July 2022. And there's a lot more to talk about in terms of the excipient ethanol. It is present in many of the therapies that we already give to babies. And I think it's just something that we need to be aware of, that low dose ethanol given after a hypoxia ischemia may be having a very different effect to that we understand as being deleterious at all in all cases. And what we see is ethanol is acting as an anti-inflammatory, antioxidant, and as a fuel in that period. So moving on to the other area that I think is extremely exciting, and that is mesenchymal stem cells. Mesenchymal stem or stromal cells are a potential paradigm shift in the treatment of neonatal encephalopathy. The way they work is not by engraftment in general. They work mainly through a paracrine effect, through release of exosomes and anti-inflammatory modulators, immunomodulation, and neurotrophic factors. They attenuate neuroinflammation, and they secrete growth factors. And in their little parcels of active cargo, they translate active nutrients and messages to dying cells. Importantly, they migrate towards the site of injury. One of the most interesting ways in which they work is through tunneling nanotubules. So these are membranous channels which mediate connectivity between the plasma membranes of connected cells. And mesenchymal stem cells inhibit apoptosis and rejuvenate damaged cells by transferring mitochondria through these tunneling nanotubules, which you can see here. So this is a mesenchymal stem cell, and you can see these very healthy green-looking mitochondria tunneling through them to this inflamed microglia and injured neuron. So this is one of the ways that they work when they're freshly in the area of injury before they themselves die, and they rejuvenate the cells by reversing the shift from anaerobic glycolysis to oxidative phosphorylation. They restore the bioenergetics, and they replace the fragmented sick mitochondria with their healthy active mitochondria. We give our stem cells in our model, which I'll explain in a minute, intranasally. Intranasal delivery bypasses the blood-brain barrier. It goes to the olfactory route, the trigeminal route, and the perivascular route. And I want to just mention 2 rodent studies that gave us the confidence to move into the large animal model. These are from the group in Seoul, looking at the rodent model, neonatal rodent model. And you can see at P7, the injury is defined here. And then after this, the stem cells are given prior to hypothermia. And the combined treatment group is on the bottom, and you can see with hypothermia plus stem cells, there's a significant reduction in injured area on MRI. The group then went on to see whether giving stem cells after hypothermia was equally effective, and it was. In the combined hypothermia plus stem cell group, you could see a much reduced infarct volume. And then came some work done in Ursula Felderhoff's lab, looking at P9 mice who were given stem cells 3 days after hypothermia. And this set us thinking very much in a concerned way what could be going on, because these mice had a worse outcome. What seems to be happening is that if you insert the mesenchymal stromal cells into a situation where you have a pro-inflammatory milieu, you will switch it back to an anti-inflammatory milieu. Whereas if you put them in as an A to an anti-inflammatory milieu, you can ramp up those stem cells to produce more inflammatory cytokines. And so what Ursula and her team are thinking is that giving stem cells 3 days after hypothermia was at a time when there was probably not a high pro-inflammatory milieu. So timing is really important. We looked at, in a small group of animals, the effect of intravenous versus intranasal human umbilical cord mesenchymal stromal cells as an adjunct therapy with cooling. Taking you through this, we had cooling after hypoxia-ischemia and vehicle given at 24 and 48 hours, hypothermia plus intravenous stem cells, and hypothermia plus intranasal stem cells. In our model, the piglets are ventilated and undergo neurocritical care for 72 hours. They're cooled from 2 to 26 hours, and they undergo continuous EEG and MRI, MRS at 2 time points, and then are euthanized 72 hours. What you see here in the EEG recovery was that there was more brisk EEG recovery with the intranasal stem cells in green. There was improved brain energy metabolism in green compared to no stem cells, so compared to cooling. And looking at the immunohistochemistry, there was almost no cell death in the intranasal stem cells in the white matter, and significantly increased oligodendrocyte survival in the white matter. This gave us confidence to then move on to a larger study called the Instinct study, which is ongoing in Edinburgh at the moment, which is intranasal stem cells to improve outcomes in neonatal encephalopathy. And here, this is some work that Ali Mintoff is embarking on as her PhD, and this is her beautiful diagram. In this study, we have 4 arms. We are exploring the safety and cytoprotective efficacy of intranasal human umbilical cord stem cells, giving them at 12 and 36 hours. Similar model, vehicle, hypothermia and vehicle, stem cells, and hypothermia and stem cells. This time we're looking at males and females, and we are hoping to see if there's any effects of gender, and we're also hoping to track the stem cells using 19F MRS. This is our piglet intensive care unit, and just to show our 3T MRI, this is a prototype made by Lammers Medical, similar to our LMT MR compatible incubators used for babies. And this is the piglet going in to have the 3T scan. And just of huge interest to me is the synergy that there seems to be between MSCs and melatonin. And this is a recent paper out this year suggesting that melatonin actually acts with stem cells to trigger the formation of these tunneling nanotubules. It also ramps up the mitochondria in the stem cells themselves. So the two together, melatonin and MSC, seem to be a dream team. So I haven't time, unfortunately, to go through too much detail of the new therapies for LMICs. As we talked about earlier on in the talk, we are in a situation where combination with hypothermia is not really an option in all settings, and we're looking at single therapies or indeed therapies, combined therapies such as azithromycin and melatonin. So these are some of the agents that we are looking at together with the Bill and Melinda Gates Foundation in a pipeline of models. And the aim really is to find therapies that are relevant in all settings. First of all, we need to have therapies that are given at the right time. We need to work out whether they should be with cooling or without cooling. And we also need to probably work towards understanding cell death in more detail and work out whether there are some therapies that should be given to males predominantly or to females predominantly. And this is where I think we might be in 5 years' time or so, more tailoring our therapies for specific patients. So I'd just like to thank the neuroprotection teams. None of this work would be possible without their really hard work, 12-hour shifts in the basement of the UCL lab and in the new lab in Edinburgh. And I'd also like to thank my collaborators across the world and my funding bodies. Thank you.
Well, thank you so much, Nikki. That was an amazing journey and a fascinating talk. Really wonderful. Thank you so much. There have not been so many questions yet in the chat. So maybe Luca, would you like to ask something to Nikki?
Well, I'd like to spend a couple of hours speaking of the fantastic and marvelous things that Nikki is doing. Can I comment a couple of things? First of all, ethical issues. So she's been so good to differentiate research for so-called Western countries and the rest of the world, so in a different way, and appreciated a lot the differences in between what is behind the prenatal asphyxia or HIE in terms of with sentinel events or without sentinel events. So I think this is, even in our countries, is a major issue because we haven't got so many good registries to understand how many babies are coming from sentinel events. We got some only sparse studies giving us the number of which kind of prenatal asphyxia we're facing. You mentioned studies, but I mean, maybe each country has different numbers, even inside Europe. The second point I love, honestly, is about how cautious we should be, because neonatologists, we really very, how to say, easy to have enthusiasm for therapies. And therefore, you mentioned, you highlighted something that is a worrying sign, no? That is not a magic bullet, hypothermia. And the white matter potentially is a sort of vulnerable area of hypothermia. And I think we had already some sort of sign of it, because when we were seeing the pre-cooling white matter lesions, I remember the paper from Linda and Francis Cowan on Lancet 2003. I think the percentage was around 3% of white matter lesions, giving a sort of flavor of chronic insult. While there are papers now focusing on 34 and 35 weekers, really above 20% or 15% of lesions in the white matter. So I think you're doing a fantastic job. You choosing molecules, you choosing a very cautious approach in research. So I think it was one of the best talk we had in our sessions. So I would like to spend something on this field. So you are really so pioneering in terms of research in this field that it was a fascinating talk and I was really admired. That's my comment.
Thank you, Luca. I couldn't agree more. Before we go to the questions, maybe I can ask a question as well, Nikki. You talked about labeling the stem cells in the piglet model. And of course, I'm always very interested what happens to these stem cells when we give it to a newborn who is not sedated and has got a different nose than a piglet. Is there any way we can label them as well using this 19F in a human or something else maybe?
Yes. I mean, I think in order to take this into clinical trials, we need to have some understanding of where they are. I'm not sure we would be able to do these sort of experiments in babies, but let's see how we go with piglets. We're only at the beginning of this, and I think it's, I think it's going to be exciting. You can also label the cells with fluorescence in the lab and try and track them that way. Of course, we're giving human cells to a piglet, so you can also track them on the HLA-DR way. But I think it would be very nice to track them in vivo in a serial way. So I don't think this is something that we'd be able to do in babies, but it's, I think, enough to do it in vivo piglets. So let's watch the space, see.
Okay, well, there have been quite a few questions coming in the chat, so maybe
we warmed up.
Yeah, we can have a look at them. So the first one is from Bharat Vakaria asking what makes us believe that darbepoetin will work when EPO doesn't work?
Oh. So thank you for that. I didn't spend time talking about darbepoetin, and I know that there's some work going on with this as a monotherapy. Well, I think what the studies have shown is that on its own, EPO works. EPO has an effect, but when it's used with cooling, it doesn't seem to have an additive effect. So that's as far as I would go. And I think the trials that are ongoing in LMICs with a single therapy of darbepoetin is, these are trials that are important.
Well, maybe he talks about it because Manon talked about darbepoetin in our stroke study. But of course, those children are not cooled. So yeah, that's different. Maybe he refers to that one. Then can we use melatonin with EPO in Uganda, Africa?
Well, I think there's still some work to do with getting the formulation of melatonin. That's what we're actively working on at the moment. I would not use the two together because one of the things that I showed you is how the metabolomic change or effect of melatonin completely swamps any metabolomic effect of EPO. And so if you think this downstream, the beneficial effects of melatonin are likely to totally overwhelm any beneficial effects of EPO. And I think we need to make sure that we are not doing any harm. There were more adverse events with EPO in the HEAL trial, and so I would not use that combination myself. I think what we are trying to do, and very much keeping Uganda, Sub-Saharan Africa in our mind as potential sites for early phase clinical trials with melatonin as monotherapy, or indeed azithromycin, which I didn't have time to talk about. These are therapies as monotherapies that are very safe as far as we can tell. And I would be using those rather than thinking of EPO in this situation.
Right. Then there are a few questions about breast milk or other kind of additional nutrition, stem cells in the breast milk, whether that could be having a beneficial effect.
Yeah, absolutely. I think there's a very nice paper looking at the number of stem cells there are in a similar quantity of breast milk compared to our very concentrated soup of 30 million stem cells that we give intranasally. I don't think there's quite 30 million in 0.5 of a ml of breast milk, and it's all down to the numbers, really. And you need that sort of number to migrate in significant, way into the brain. So I think if we're talking about intranasal breast milk, I wouldn't be doing it. I don't think it's, there's enough. But if we could be using breast milk for mouth care, for trophic feeds, there is some unpublished evidence that this actually reduces your cytokine storm, reduces the systemic inflammation. And I think breast milk is really important in that way.
Yeah, there was a paper a couple of years ago from a group in Germany, and they used the stem cells every kind of time they gave the breast milk, intranasally as well, and they showed some possible effect on the grade 4 fibrosis. So I think maybe the question was kind of referring to that paper.
Yes, I love that paper, but I think that was preterm, and I think that's perhaps more a chronic picture where regular installation of breast milk in the nose at regular time points may help the evolving brain injury, but what we're dealing with is a absolute catastrophic hypoxic ischemic insult where you need emergency services and you need all your stem cells to be mobilized quickly to help. And I must say, one of the things that I changed in my model was to move the stem cell application to slightly earlier. I had been thinking of giving them the first dose at 24 hours, but because we're wanting to modify the inflammatory milieu, and it's likely to be highly inflammatory at 12 hours, we are giving it earlier. So I think I know that paper and I love that paper, but I think we're in a very different situation to the preterm.
Yes. I also like this question, and I would like to add a question to it, whether ethanol vehicle in the formulation of melatonin had any sedative effect. And then I also wonder, of course, whether it had any effect on the background pattern of the EEG.
Yes, so I think we're talking about a very, very low level of ethanol. It may have a mild sedative and relaxing effect on the babies. I think we're talking about, if we think of glasses of wine, we're talking about a very, very small glass of wine. So it may well be. There are a host of preclinical papers in rodents talking about low infusions of ethanol and the protection that achieves. And in answer to your question, Linda, we did see a recovery in the background activity with the ethanol vehicle by itself, albeit more less early recovery than with the melatonin ethanol. It was more like 19 to 24 hours rather than 12 to 19 hours, but it was definitely there. And I think what was so remarkable was the effect of ethanol on the oligodendrocyte survival. That was really, and I don't think I'm the only one to have seen that. That's also been seen by Alistair Gunn's work in the fetal sheep.
Thank you. Luca, would you like to select any other questions that are you looking at and thinking?
No, you like to involve me, and I love the idea of can I make a sort of joke, Nikki? We've been a sort of familiar environment. So think that I'm coming from an extremely rich foundation, and I have to give you money, and I trust you a lot. I told you about my sense of admiration. But because the feeling I had also listening to the talk is that in a very enthusiastic way, we went into very detailed mechanism of the disease. And sometimes we using even some drugs we had to use for or tried for preterm babies. So in the way that you mentioned radicals and the inflammation, no? And so at the end of the day, it seems like that medicine is going in the same direction of making a damage or to the brain. So how? Because here we have a proper disease with proper lesions. And if I look in the past with my eyes, I couldn't find a convincing, not single bullet, but explanation how we managed to reduce, for instance, PVL. So do you think we may have more efforts in understanding the labor part also than the therapeutical part of this still ongoing problem of perinatal asphyxia? So how should we be convinced at the foundation to put a lot of efforts in the therapies while we are not doing such a lot of efforts during the labor part of the life, speaking about asphyxia?
So Luca, I think it really goes without saying that we must
just like in front of a glass of wine.
Yeah, we must prevent and that's the most important. We must prevent asphyxia. I think that's what you're getting at the and indeed the incidence of neonatal encephalopathy is decreasing. Certainly there's data from Wales, there's data from the Netherlands, and there's data from London in the networks just over the last couple of years. I think that people are much more aware. Training is better, awareness amongst the younger trainees. So yes, we are making inroads, but it still happens. And, we're never going to stamp it out completely. And I think also what we're now trying to do is to fine tune the neuroprotection. We're trying to improve the white matter integrity, which could make such a difference to people's lives as they grow up. I mean, I was stunned at the case that you talked about, Linda, who everyone rejoiced early on. This little girl is going to be perfect. She's wonderful. But what a difficult life she's had, and if we can use melatonin or any of these therapies to actually just allow them to achieve their full potential, that's great. But it absolutely, it should be, on the first slide that prevention is better than cure. And so we need to be, looking at.
We were happy to hear that you were very linked with the Melinda and Bill Foundation, because I think they did a fantastic job in the way of measuring that kind of problem. No? So you mentioned that the feeling that asphyxia is decreasing in many countries. We had the same, and you have already the data of a famous disability adjusted life years corrected for perinatal asphyxia. So they did a fantastic job, and I'm really happy that you have their support, because I think they've been extremely good on that, because we can measure in the same way all over the globe these kind of problems. Yeah.
And Nikki, one more thing, the melatonin especially, you're talking a lot about the white matter, but as a neonatologist, we are mostly concerned about injury to the deep brain, right? And do you think that there will be some kind of protection there as well? Because that's so important for cerebral palsy.
Yeah.
So can I add something with that? Is it going in the same direction that we're going to see the same kind of vulnerability? At the end of the day, is more important the white matter, like for PREMS. If you have PVL, if you have pancreatic lesions, if you have IVH, at the end of the day, the problem is white matter. So it is something that is going in this direction too, for what we understood.
So just to sort of define what I think we should call neuroprotection, I think it should not be neuroprotection, it's brain cytoprotection, because we're trying to protect not only neurons, but glia, oligodendrocytes, microglia, you know, there's a whole host of cells that we should be trying to protect. But in terms of melatonin, yes, I've focused a lot on white matter, but the nice thing about melatonin is it doesn't just improve white matter outcomes. We, of course, put our voxel in the basal ganglia as well as white matter. We've seen in many of our studies benefit of melatonin in the deep gray matter, basal ganglia thalamus. So it's a pleiotropic, multi-pronged and multi-region cytoprotector, and protects not just neurons, it protects, you know, all of the cells.
Okay, thank you. Well, I'm looking forward to all these trials that will be coming on soon. And Luca, would you like to close the meeting?
No, I leave to you, but just I say thank you so much, Nikki, again, because it was a fantastic experience to listen to the fantastic job you've done.
Thank you for including me.
Me too.
Thank you very much.